Welcome to another episode of Main Street Mental Health. I'm Shannon Paul, licensed professional counselor, licensed clinical social worker, and substance abuse professional in the state of Wisconsin. I've worked in a couple different locations in Wisconsin, both northwestern as well as south central, and been in the field for quite some time. Today, we're going to be talking about a challenging topic that I think a lot of times both individuals experiencing this particular condition or disorder, as well as providers, struggle with greatly. And I'll point out that this particular condition seems to be more prevalent in our offices, certainly, whether it's we're doing community-based work or if we're doing office-based outpatient work, it is seen in quite regularity. And it's called borderline personality disorder, or BPD. Some people refer to it as that. And today we're actually going to be covering an alternative approach to potential treatment considerations. So I'm pitching this as an alternative. It does include some traditional methods, some more recent developments in the field, but can be very, very hopefully helpful in the long run. Again, often individuals that experience borderline personality disorder, are struggling with it for quite some time. So probably and proportionally, services are often offered for extended periods of time as well, whether they're different types of services or the length of time in general. So we'll get into it though, as quickly as we can. And again, this is just a new take, or I wouldn't even say that. It's a take that's been discussed throughout. If you do an internet search, you can find some various locations, but it's not a real popular viewpoint. And this, for myself, this developed from my experiences working in the substance use realm. And if you were to look at addictions, whether it's substance use or process addictions, such as like gambling, for instance. If you look at a gambling, diagnosis in the DSM-5 or the newer version, and if you exchanged problem gambling with some of the symptomology that you see from individuals suffering from borderline, you actually see some similarities between some of those symptoms. And often when I have shared this information, I've actually replaced those words and shared that in trainings with staff or whomever, and they usually guess borderline as the diagnosis we're talking about. And then I reveal that it's actually compulsive gambling in the same diagnostic and statistical manual. So it's a very maybe this is controversial, but at the same time it's utilizing some services and treatment modalities that are common in the substance use world, the addictions world, and kind of intertwining it with some of the mental health efforts that are out there currently for folks with borderline personality disorder. So this is both kind of to be considered both as a provider as well as somebody who's experiencing these symptoms and these concerns, and whether it's newly diagnosed or something that people are experienced with and lived experience with for quite some time. Maybe it's something to take a look at, talk to your local providers, your current provider, your new provider, or whatever, to maybe incorporate some of these kind of modifications, alternative ideas. So it's this particular issue can be very, just speaking from personal experience, as well as throughout supervision and working with people that work with individuals with borderline personality disorder, it definitely takes your breath away sometimes in terms of some of the symptomology and the behaviors and the choices and so on and so forth. That it doesn't ever end, it never stops surprising you in terms of how it elicits itself and how it shows itself. And it definitely is one that is, again, like I said, it seems to be more and more common in our offices. Um, I will use the acronym BPD for the most part as we talk. Um, Believe it or not, BPD has a treatment modality that was specifically designed to help it, and that's DBT, which is dialectical behavior therapy, and really probably one of the go-to programs um, over the last decade for sure. Whenever Linehan kind of developed it. I have been trained in that to some degree. I think it's great. To me, um, the structure of it is very, very important for individuals with BPD, and it can be very helpful at developing some uh, you know really life skills. Whether it's emotional regulation or distress tolerance or communication skills, things like that. So it can be very, very helpful. I don't know if it covers everything, though. I don't know if it necessarily covers all the nuances and challenges that might be out there, but certainly as part of a kind of a tapestry of services and treatment modalities, definitely if that's available to someone, take advantage of that. Um, I will say that typically BPD is something that's best served individually, generally. Groups tend, especially process or therapy groups tend to be a bit of a struggle. That's where the DBT groups are very effective because I think their structure is so well thought out and so well set up that it really doesn't allow that kind of process time to a great degree, where I think that's where a lot of individuals with BPD really kind of show their stuff, and that's when they are really, really um, motivated to kind of share their crises of the day, their crisis of the week, crisis of the month, over and over and over again. So they can definitely take over a group meeting if allowed. So I think the structure is very important. Um, yeah, they describe just many, many moments of agony, distress, and then also compulsions as well. And I think counselors and providers that work with folks with BPD, they have some of their own struggles, and whether it's they call it countertransference, whether they call it exhaustion. I have heard it said over the years many times that there is kind of the bucket is a little bit more empty, after doing some work with folks with BPD. But as with any working with any kind of condition, it definitely taps into the reserves that people have. So keep that in mind. But it can be challenging for everybody. Um, Here's my working hypothesis that BPD could be a process or behavioral addiction. So let me say that BPD could have some elements of addiction, whether it's a process addiction such as gambling, relationship, whatever, behavior or a behavioral addiction. So, like substance addictions, BPT has a genetic component. So, the research that I've found, typically it's at least a third, sometimes to almost, between a half, 50%, or even, 60% of individuals with BPD have a parent, a genetic biological parent, with the symptomology of BPD, whether they're diagnosed or not. Um, just consider that substance use individuals is about a third of people. In BPD, it's even a little bit higher. So keep that in mind. There is a genetic component. I would also throw out, which I might not describe in here. There seems to be a activating event that happens, or events that happen, usually in childhood, for individuals with BPD, that there's some sort of trauma, um, uh, injury, whether it's attachment or otherwise, that occurs that almost seems to kind of bring it out. Not unlike substance use, where you might have genetic predisposition to substance use issues, but if you never partake, it's not as much of an issue. Behaviorally, it might be to some degree, but it's if you don't drink, you're obviously not going to develop an addiction to a substance. So it's seems to be an activating event needed too. Um, I I will throw this out there as well. A lot of times with clients, I'll ask if a client with BPD, if one or both of their parents had an issue of substance use. And I use it kind of as a diagnostic tool, but often you'll see that. Um, and sometimes, these particular clients will say, I have an addictive personality. You've heard that term probably before. I have an addictive personality. So you hear that often with individuals with BPD, whether it's diagnosed or not. I'll throw out, anecdotal reports from BPT often indicate a need to act on self-harming behaviors. So think about that. So any type of, when we talk about self-harming behaviors, it ranges, of course, but typically cutting. I had an individual that, unfortunately would swallow, kind of different types of things that were not healthy and dangerous. So they would actually eat them or swallow them. Yeah, there's a whole range of things that people do, unfortunately, that are self-harming or injurious behaviors. And there's almost a compulsive and or relief after partaking in those behaviors, as if having a drink of alcohol, or 6 drinks of alcohol, or whatever. So there's that need, and that got me thinking about that addictive compulsive process that's going on, and then kind of connecting the dots. I have heard it from clients that report it being a craving, so whether it was self-harming thoughts, compulsions, things like that, that it felt like a craving. Um, Both clients with substance use and BPD often report a feeling of emptiness, or a void, or just not knowing who they are. That symptomology wise for BPD is one of the main tenets, main symptoms for diagnosis, is just that identity concerns. They often look at behaviors or substances to kind of fill those voids and that emptiness. So keep that in mind. Um, I would say probably all clients with substance use or borderline personality disorder have, they report it certainly, but they have bouts of anxiety, depression, anger, hopelessness, highs even too. So I would say you see an inordinate amount of individuals with BPD having cross addictions, such as substances, sex, gambling, eating disorders, things like that. So and I use the cross addictions kind of in quotes on that. Um, might be some disagreement on, equating eating disorders with addiction. But there's certainly compulsive, obsessive, and compulsive kind of qualities to it. Um, it Clients with BPD and substance use often have significant trauma backgrounds, whether it's that activating event or more. You see that a lot with both populations. Um, Yeah, we talk about in the substance use world, we talk about emotional and mental lapses or relapses before the actual relapse with the substance or process. It's similar in borderline personality disorder, that the individuals are contemplating, pondering, thinking about, feeling, certain ways with certain triggers that contribute to maybe the activity of self-harming or declaring suicidal ideation, self-harming and suicidal ideation, very, very unfortunately common with BPD. Um, yeah, I just know that many of my clients, just even when I saw last week, talked about some of those self-injurious behaviors or even the SI ideations as being addictive urges or compulsive. So just to kind of reinforce that feature of this. Um, Here's a special note on substance use behavior of war stories, which can happen often in treatment settings when clients discuss quality, quantity, near misses, arrest, and intoxicated experiences. These are generally considered contrary to treatment efforts. So keep that in mind. So in the substance use world, war stories are typically, we try to deviate from those. We try to interrupt those. We try to minimize those. And a parallel could be drawn to individuals with BPD, and they often verbalize preoccupation with their crisis of the week and crisis of the day, affectionately in our field calling cows and cods or cods and cows, crisis of the day, crisis of the week. And they can take many forms. They can be mild slights that maybe somebody, treated them wrongly that day or that week, to higher levels of insults. Again, it's the challenge of struggles and so on and so forth. And then they usually have suicidal ideation or self-harming ideation as a result of these things. And relationships are, as we'll talk about a little bit later, the push and pull of relationships. So personal relationships are often pretty chaotic and pretty inconsistent. It is challenging to find long-term friendships with individuals with borderline personality disorder, as they burn right through them, in its distress. So, anyways, so keep those parallels together. There's just from the interfering behaviors, which in DBT is often discussed, treatment interfering behaviors, or TIB, acronyms for everything, my apologies. But they can come in many shapes and sizes, but often for substance use, it's the war stories, and really in many regards with BPD, it's cods and cows, crisis of the day, crisis of the week. Your basic diagnostic criteria for borderline personality disorder, you can research that, look that up. I'll highlight a couple of them. A pervasive pattern of instability of interpersonal relationships. I just mentioned that. Affects are quite unstable as well. Impulsivity beginning in early adulthood are very common. They typically have 5 or more of the following. Fear of abandonment is number 1. That's significant. I highlight the next one, unstable or changing relationships, very similar to substance use. Number 3, unstable self-image, struggles with identity or sense of self. I often, almost as a diagnostic tool, I will ask clients, who are you? And if you want to see somebody squirm that has some borderline personality disorder qualities, that's a question that usually causes some happy feet and some discomfort, certainly, is who are you? And they struggle with that one sometimes. Number 4, impulsive or self-damaging behaviors, excessive spending, unsafe sex, substance abuse, reckless driving, binge eating, et cetera, et cetera, et cetera. Also very equated to the substance use world as well, the self-damaging behaviors, drinking or using drugs, and all the others all kind of come along. Suicidal behavior or self-injury, varied or random mood swings, constant feelings of worthlessness or restlessness or sadness, problems with anger, frequent loss of temper, and or physical fights even. So aggression, reactivity, sensitivity, pretty high typically, and you see that with substance use as well as BPDs. Sometimes you'll see stress-related paranoia or loss of contact with reality. Sometimes I give the example of looking across the room, somebody's maybe staring in your direction with a frown, and a person with BPD can write a book on how insulting or slighting that is to them. And that person might be looking past them to somebody else, might be just thinking about a hard moment, so they have that paranoia, and kind of as a cognitive behavioral therapist would, it's just that, personalization from, someone else's just look, and it's typically, rationally, it can be looked at as probably has nothing to do with me, so keep that in mind. So those are the diagnostic criteria that people have with BPT. So the paradigm shift that we're looking at in terms of the approach, in terms of whether it's something you want to deal with yourself, let's say you're having some of those symptomology that we've described and you're struggling with those things for a period of time, consider this. So BPT may be very well viewed as a process addiction that requires recovery efforts in as much as the substance use world. Um, and the good news about that is that a client may achieve recovery. So often in the substance use world, um, recovery is always kind of the goal. It is a challenging area and population to work with as well. Often when you work with BPD, um, it's often just mitigating symptoms of the day to get through. Therapeutically, you're not looking too far down the road in terms of recovery-based things. So I think this is kind of a strength-based approach as well. So it's something to consider. Um, Use lapse and relapse language with clients or yourself. Shift the perspective from personality to neurology, because there is, again, we talked about the genetic neurological basis to BPD. So, and if it is a process addiction, what are the treatment needs that you, if you're a person looking at type of thing, or you as a provider working with a client or clients, how to look at it. So consider that alternative approach. We developed a treatment protocol and enhances what's already being done traditionally by adding treatment perspectives and approaches typically seen in the substance use field. Often, clients with substance use concerns have better outcomes with a holistic approach. So, our treatment protocol, one to consider an alternative would be a hybrid approach, adapting features both from the SU field and the current efforts for borderline. So, that's something to consider and think about. What do we do first? What's something you can do first, whether it's for yourself or a loved one or someone you're working with? Consider stages of change. That's something that's very popular in the addiction field, the substance use field, process addiction field, is to kind of figure out where they're at, and just to give you an example of that, there's 5 stages of change. And the first one is pre-contemplation. People in this stage may wish to change, but for immediate future have no plans to do so. They might not be aware of the potential benefits of services or change or anything like that. They might be disinclined to do because of past failed efforts in treatment or, whatever their lived experience is, or lack of just available energy. So pre-contemplation is a tough spot to be. And that usually indicates they're not planning on making any type of change for like the next 6 months. So nothing on the near horizon. What can hold you back? A sense that making necessary changes would require too much work or discomfort. Hopelessness from previous failed attempts really seeps in there, limiting the beliefs about what's possible or permissible for you. So that can hold you back. What can move you forward during this time period? A positive or negative life event, becoming aware of negative consequences of not changing, recognizing of changing might be worth it, challenging old beliefs, developing a stronger sense of self-worth and confidence. So those are things to really focus on if you're stuck in this kind of stage 1 or pre-contemplation. Number 2, stage 2 of stages of change is contemplation. And those in contemplation stage are thinking about taking action, but aren't quite ready and don't know how to get started. Contemplators often think they might make the behavior change within the next 6 months. They're open to information and feedback in the stage. The pros and cons of potential change feel about equal. So it's kind of in the middle, ambivalent to some degree. What can hold a person back? Lacking a powerful sense of urgency or motivation, difficulty balancing competing priorities, fear of change, a sense that now isn't the time and that you aren't equipped to make the change you desire. So keyword there is there's a desirable change in mind, and that's usually a good sign if you identify that. What can move you forward? Feeling excited about the possibility of a positive shift in your life, connecting with core motivations, maybe values, being inspired by role models or success stories, experiencing last straw, negative consequences of old behaviors, maybe even an incentive to change in your environment, and then learning a new skill or acquiring a new perspective. So those things can kind of catapult you forward, maybe ever so slowly, but they can move you forward. Stage three is really there's two different names for it. Well, some people call it, I call it preparation, but some people call it determination. Um, excuse me. People in preparation stage are getting ready to take action. They're more decisive, they're confident, they're committed, they're developing a plan, and they've already taken small steps just by developing a plan. The pros, the pros of making the change clearly outweigh the cons, but there's some work to be done before meaningful action can take place. So, what can hold you back in this stage? Underestimating your need to prepare. So, being planful is important. And skipping straight to the action phase. How often I've seen this where I stopped today, and then 2 days later I started again. So there's not much planning that goes into the stopping, whatever the behavior is. So skills, knowledge, confidence, support, um, you know, and sometimes people are afraid to ask for those things and acknowledge those things, but um, that's where support, whether you have somebody in your life, if you're going to, venture through this on your own, I wouldn't. I would recommend being with, somebody to guide, a coach, a peer support, a counselor, a group of, a program. That's where the support comes in. So taking initial steps, this is what can move you forward. Do the research, ask people, talk to people, acquiring equipment of some kind, engaging in a coach or a mentor, establishing a start date on a calendar. That's a big commitment. Telling friends and family about your plan to change. That's a commitment. That's dedication. That's letting them know, and they're more apt to support you in those situations. So keep that. So you kind of build excitement and confidence by preparing. The next stage is action, and that's beyond just thinking about it or preparing for it. A person that wants to do this has actually begun doing the things, or a lot of things. Could be one thing, could be a lot of things. Doing something differently, experimenting with things, expanding efforts, things like that. Whether it's small in the beginning and maybe larger things moving forward, any action is equated here. So. What can hold you back? Expecting tangible results too quickly. So sometimes it does take time. I often, in our field, sometimes it's like, how long did it take you to get into this level of concern? And often it's years, So I usually kind of equate, in terms of expectations, kind of saying, well, it's going to take a while to kind of build your way back out of this. It took you a while to get into it. It's going to take you a while to get out of it. So I've worked in the weight loss arena in the past, and that was the same message that they would say there is, yes, it took you quite some time to gain that weight. It will take some of that time to lose that weight. So same kind of analogy there. Sometimes things that can hold you back in action is competing commitments, a busy life, busy things, other responsibilities, so on and so forth. So there is an element of carving out the time dedicated to this, to recovery efforts. One of my friends says active recovery, Shannon. So keep that in mind as well. Good support systems, prioritizing key activities, priority listing things, very important during this time. And then celebrate the small successes as you're going through this. No matter how small, just celebrate it, savor it, cherish it. There's a stage 5 is maintenance. And that's where you this is somebody that's been in the action stage for at least 6 months. And it's incorporated into your life, basically, some of these changes, whatever those might be that you're hoping for. We'll just move forward out of stages change. I think we understand that piece. There are some people that consider a 6th stage, and that's termination. I don't know, in recovery, I think that maintenance stage it might mutate and change into maybe lesser, smaller efforts, but I think it's going to be there for the long haul. So we call this RPP, relapse prevention planning, which is either in the substance world, obviously it's relapse from a substance or a process. Often in the mental health world, it's called crisis planning. I think you can really merge those two things together. There's often overlap between the two. And I think this is a way to go, is to actually put it down on paper, put it on your wall, put it on your refrigerator, have it apparent, have it ready, have it visually ready. And that, oh, I can do that instead. So I usually tell people consider developing a robust trigger list of all things that contribute to triggering, whether it's for people that have experienced trauma, it's flashbacks. For people that have anger issues, that's something that triggers anger, sadness, hopelessness, downness, anxiety. Whatever the trigger is really, really consider all those types of things. Be mindful of halt issues in as much in the substance use world. Halt is a very common thing to discuss. I'll explain in a second. But halt in borderline personality disorder, in terms of the behaviors and the symptoms that come along for the ride, I think halt is very important to be aware of as well. And halt stands for um, different things. Hunger, that's the H. A is anger. L is loneliness. And T, tiredness. All those are kind of preparatory triggers. Those of us that are parents, it's you got that hungry, tired kid after school. Whew, their behavior is so much different than it is after they've had some rest or after they've had some food. And it's really no different in BPT in terms of symptomology that kind of erupts. Is you look at the whole things. So for yourself or other people. Document your high risk situations like you do in substance. If there's certain people or places that really contribute to concerns developing, symptoms flaring up. In the substance use world is, I know people that drive a couple miles out of their way to avoid certain spots. In my area, there's some downtown gas stations that people should not go by because they've bought there, they've used there, um, their friends and family buy from there or whatnot. So those are ways around high risk situations. And then complete this relapse prevention plan as quickly as possible. It might be similar to crisis plans that are already developed, that you have developed or whatever, but updated it frequently. If there's modifications or tweaks that you need to do to it, constantly be attending to it. It's very fluid. A little bit on triggers and high-risk situations. Any solid relapse prevention plan includes awareness, vigilance, planning for things that consistently trigger problematic emotions, thoughts, and behaviors. That's key right there. And then the high-risk situations generally involve people, places, or circumstances that contribute to lapses or relapses. Let's avoid them at all costs. So whatever those might be. Here's a comment on the use of DBT or dialectical behavior therapy, as well as CBT, which is cognitive behavioral therapy. As I mentioned earlier, the structure of DBT and CBT can be of great help. There's no doubt about it. Group DBT, along with individual services, can be very useful. DBT adds the emotional quality of the client's experience, as well as promoting the awareness of dialectics or the space between black and white. Often, when we're struggling, we see black and white. We see the extremes only. We don't see that gray in between. And sometimes that's where we want to focus our efforts. It's like, where are all the possibilities in between? DBT also focuses on suicidal ideation. And with the paradigm shift, these behaviors can be viewed as symptoms of cravings, lapse, relapse, dopamine releases, even of a process addiction. Mindfulness, which is highly practiced and trained and skill built through DBT, helps provide structured awareness, building along with developing emotional regulation skills. And in substance use, getting through the craving is an early recovery challenge. So not much difference there between those things. And then CBT skill building can be a good foundation as well. Again, that's where you work on cognitive distortions and rational responses to those things and getting good at identifying them when they happen. If you identify them and your awareness builds and you can identify them, boy, your ability to battle them goes way up, thus lessening their impact. The structure of DB2 groups and any other group with psychoeducational or experiential components can be very, very helpful. And if there are those types of groups around, whether it's IOPs, whether it's through a local clinic, IOPs would be intensive outpatient. can be very, 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 very helpful. Clients with BPT issues need positive reinforcement for practicing pro-social interactions. Often we describe the interactions and relationships being very chaotic and really up and down. But when they do have moments of appropriateness, that's when at least some level of acknowledgement is important. I would probably err on muted or a mild, celebratory kind of a thing. For some reason, that's just my personal experience. That sometimes when you overdo it, it might trigger an oppositional response. So keep that in mind. Um, Polyvagal theories. I did some training a couple years ago on polyvagal, and it's revolving around the vagus nerve, which is actually a very important nerve to our nervous system. And often our clients with BPD, as they call it, they have injuries to their nervous system, which result in a dysregulated response to distress. So the simplest thing is is they might be activated in that fight or flight response much more often than your standard individual human being. So, and I think there's some merit to that. I'm sure, as studies go on, this will be kind of, very verified and very important to know. That vagus nerve is definitely affected. And that vagus nerve is so important. By the way, that vagus nerve connects the base of your brain, the emotional center of your brain. It actually goes to your vocal cords, it goes to your heart, and it goes to your diaphragm, as well as it kind of expands out. If you've ever experienced a broken heart where you actually feel it right here, that's your vagus nerve being injured. And it actually physically, can, come through. So often people with BPT spend a large amount of time overly activated, or their nervous system is in fight or flight. And sometimes they're in that collapsed freeze state as well. There's fight, flight, or freezed, or collapsed state. I've heard phrased in many different ways. But injuries tend to be traumas, neglect. Sometimes there's a genetic predisposition as well. And then being polyvagal informed can be super helpful. There are certain foods and activities that can promote a healthier vagus nerve and experience. And again, anything you do to support that is going to really reduce symptomology in a BPT individual. So there is, I'll probably share this screen as well with you. There are 12-step programs that have some focus on BPD. There's actually the 12 steps for, borderline personality disorder. There's also for self-injurious behavior as well. For those people that maybe have a faith-based value in their life, can be very, very helpful. There's that support stuff, people that have kind of going through it similarly to you, just as much as in the substance use world where, AA or NA, Alcoholics Anonymous or Narcotics Anonymous, among others, gamblers, GA as well. They can be very, very helpful. They can be very structured, which is, again, my point. And sometimes they're online or in person. So you can actually, the availability and accessibility are very high. Often meetings in a given, community throughout our areas, several meetings, sometimes even a day, but certainly daily there's meetings. So it could be very helpful to have that structure, that schedule, so on and so forth. One point I want to, on the 12 steps too, often people doing 12 steps and they actually doing step work. The normal average amount of time somebody's doing that is 1 to 2 years. So if you do meet with somebody who says, "Oh, I've been through all 12 steps in 3 months," there's probably some healthy skepticism there. So keep that in mind. Yeah, I won't necessarily, I'll share this screen with you guys on the 12 steps for BPT addiction. And again, I found this online, so I'm obviously not the first one to kind of consider this aspect of BPD. So it's out there. There's also smart recovery for those people that maybe aren't involved in a faith-based approach and nor don't want that. There's smart recovery, and I think there's elements in smart recovery that can be very, very helpful for a person with BPD, um, that you can adapt from the substance use world, the process addiction world, excuse me, to what you need to do for BPD. So smart recovery is incredibly comprehensive and structured. It has groups, it has individual modalities. A lot of it's online, so it's somewhat, you feel safer sometimes when it's, you're just at your computer screen versus having to go somewhere face to face. There are local smart recovery groups though as well, but it's the accessibility is good. The structure is very, very good, and it does talk about relapse and lapse prevention quite a long. It has a CBT focus, so that cognitive behavioral focus. You just have to adapt some of the things. So smart recovery, it's called. Medicinal supports. There is some uh, local providers, prescribers in my area that actually prescribe, various medications that would be traditionally used for substance use. They're actually utilizing them for BPD. So, for example, there's one called Vivitrol or naltrexone. Um, Hopefully, I'm saying that right. Yeah, and I think it's naltrexone. That typically was developed for alcohol and then later on opiates in terms of recovery. They're using it for BPD to help with cravings. So there are other medications that are being used for that as well. But it's interesting, you know. So anti-craving medications, antidepressants, mood stabilizers may be of help. Um, and I always, urge people to lean towards medication that's not dependency causing or has an addictive quality to it, like a benzodiazepine or uh, similar. So medicinal supports also very helpful. I think recently I've had some more training on this, and so I highlight attachment work. If it's something you're going through, if it's something your loved one's going through, or somebody you're working with, um, clients with BPD often have challenges with connection and attachment. Almost given, almost 100%. 70% of the population have secure attachment styles. You would be hard to find a BPD individual with in that 70%. I would be surprised, pleasantly surprised, but I would be surprised. Children that fail to bond with a consistent caregiver from birth to two often struggle with this issue a lot. Keep that in mind. Children who experience periods of abandonment, physical and sexual abuse, and other neglect can also develop challenging attachment styles later on. And so work on attachment could be an important piece to lasting recovery. So I highlight that one as well. Attachment, very, very important. The polyvagal and the attachment work are critical. And then there's trauma work. Clients with BPT often have trauma histories and significant neglect or abandonment by their caregivers. So trauma work can be a focus as well. And again, I would say there's kind of a timeline for each of these elements of these interventions, this alternative intervention. So some start from day one, but some might be incorporated later on in the treatment, stages of treatment. So I would say trauma work might be considered early on, but I think there's got to be a period of stability. Um, just like with substance use, I find that if you're in active use, using substances, recovering from substance use, that kind of cycle, it's really tough to do trauma work in my experience. Some people will jump right into it, but I think the stability factor, and that might only take a week or two, to get to the point, okay, I haven't used for 3 days. I'm beyond the withdrawal, or whatever it might be. I think then, I think it's possible, but I think there might be some other things to address. You know, Again, if you're doing polyvagal work, you're actually doing some trauma work at the same time because a lot of it is fight or flight, that PTSD response. So there's definitely a time and place for each of these things. Some of them concurrently. Um, yeah, just consider the level of stability. Often clients with BPD have high default levels of alertness, sensitivity, emotional volatility, SI, SH, and a lot of desperation. So trauma treatments that are out there now, there's brain spotting, EMDR, ART can help lower these default levels. So if their baseline is a 7, getting them down to a 3 or 4 would be fantastic, for their experience, their day-to-day experience. So some people do require and desire and seek out residential treatment options. So it's on the continuum of potentialities. Maybe that's earlier on um, in your treatment, marathon. But some of those can be very, very powerful. Again, um, the more structured, the better, in my opinion. So, um, and there's usually a safety component. If there's residential involved, there's usually a safety component that maybe can't be met in the community at that point in time. That residential might be a good option as well. So, keep that in mind as well. Um, Again, so just in conclusion, I just, this alternative viewpoint is really blending kind of those traditional models. Some of them are newer than others. Some of the trauma treatments are newer, with kind of a recovery orientation, not unlike substance use. And I think the blend of those things can be very helpful. Going all the way back to the beginning, we've talked about stages of change. Therein lies some of the variance you're going to see with people with BPD. Some people might verbally say, "Yeah, I'm ready to do it," and then the next day they're not doing it. So that is where there might be windows of opportunity that happen that somebody is ready to work, so on and so forth. But you'll find that with BPD is you'll have kind of inconsistent motivation. So the key is really kind of measuring the long haul as well as taking advantage of those windows of opportunity, whether it's with yourself, don't be surprised if your motivation kind of moves back and forth. But when it's ready, take advantage of it. So this is an issue that I think as time goes forward will be addressed and researched even more and more and more. And hopefully we find more treatment modalities that really can maybe shorten the treatment marathon. I give anybody credit. Number one, if you're a person with borderline personality disorder, that I want to work on it. I give you all the credit in the world, and also your providers and your team maybe that is working with you. That you're do good work when you can, and hopefully in the end you see some improvement that makes life a little bit more safe, a little more hopeful. So again, we're all a percentage of perfect, and this is Shannon Paul signing off until next time, and take care.